Good afternoon, everybody, and welcome to another British Cochlear Implant Group roundtable. This time we're talking about returning to the cochlear implant clinic. So my name is Helen Cullington. I am the chair of the British Cochlear Implant Group. If you have any questions you'd like to ask, please feel free to ask them throughout the webinar, just using the chat function on the right hand side, and I hope that we will get to answer your questions. We are going to keep your microphones muted just so that we don't get interference, and the session is being recorded and will be available on the BCIG website hopefully tomorrow. So I'd like to start by acknowledging what a difficult time it has been in the past few months. Many people have been unwell, so many people have lost their lives and continue to do so from COVID-19. So we're very sorry for everybody who's been affected by the virus. As you all know, outpatient services and hospitals have changed massively due to the COVID-19 virus. And the aim of today is to talk about the cochlear implant clinic, what has changed, what are we doing differently as we're just starting to get back into the clinic and see our patients. So first of all, I would like to ask our panelists to introduce themselves and just briefly say their background. Claire, can you start?
Good afternoon, everybody. My name's Claire Chadwick. I'm nurse consultant, infection prevention and control at Bradford Teaching Hospital NHS Trust, of which the Yorkshire Cochlear Implants is part of. I am also the mother of a hearing impaired son who had a cochlear implant about 10 years ago.
Thank you, Claire. That's great to hear. So it's really great that you have a dual hat really as an infection control specialist. Also, you know exactly what goes on in a cochlear implant clinic. So thank you so much. Sandra?
Hello, my name's Sandra Driver. I'm speech and language therapist at St Thomas's Hearing Implant Centre in London, and I work with both the paediatric and adult team. Thank you.
Sue?
Hi, I'm Sue Falkingham. I'm the immediate past president of the British Academy of Audiology, and I've been one of the key authors of the Audiology Joint Guidance over the last few weeks.
Lisa?
Hello, I'm Lisa Kennedy, and I'm the coordinator of the North East Regional Cochlear Implant Programme based out of Middlesbrough.
And Amanda?
Hi, my name is Mandy Spears. I work as an audiologist and joint audiology lead in the Auditory Implant Centre in Belfast, dealing with both adults and peds.
Thank you. So first of all, I want to thank you all for your time that you've given up this afternoon. I know that things are just busier than ever at the moment. Certainly in my clinic, we have just opened up our clinic. I work in Southampton as an audiologist. We've just opened up our clinic yesterday. So I'm really aware that it's such a busy time for everybody. So thank you so much for your time this afternoon. So most of us have opened our clinics now. And of course, we have had to all make massive changes in terms of prioritizing our patients, dealing with waiting lists, PPE, remote working. Everything is so different for all of us now. So Claire, I want to start with you, if that's okay. So you're an infection control specialist. Can you tell me what are the particular risks, what are the ups and downs really of infection control in the cochlear implant clinic?
Oh my goodness. Okay, so the most important one is obviously to prevent post-operative infections in a cochlear implant patient. Obviously, it's very detailed surgery, it carries a risk with it. So the most important thing for me is hand hygiene. And that goes for in normal times as well as coronavirus times. So hand hygiene remains the single most important thing that you do to prevent infections, whether those be wound infections, ear infections, or, for example, coronavirus infections. The second thing is ensuring that your equipment is clean and making sure that the cleaning products that you use are recognised as adequate to clean or disinfect, whether it be bacterial, viruses, or whatever you're trying to do. Always read the manufacturer's guidance about cleaning, but also if you're unsure, take advice from your infection control team, who are really good at advising on all sorts of disinfectants and cleaning regimes for even intricate pieces of equipment that I know audiologists and cochlear implant centres use. And I think those would be the two key issues for me, is hand hygiene and equipment cleaning.
As you know, Claire, in our audiology rooms, in order for the rooms to be sound treated, everything is padded, everything is soft. So I think we feel comfortable with cleaning the hard surfaces, stripping the rooms out as much as we can, but we do need those soft surfaces in order to cut down the reverberation times in the room. So how should we deal with the soft surfaces?
I think the soft surfaces are okay because it's more about the pieces of equipment that you're touching all the time. And the soft surfaces are usually chairs and walls and carpets, which usually it's people's feet or what they sit on, which isn't the risk. The risk is really your hands and what your hands touch. And your hands usually touch either hard surfaces or pieces of equipment. If you're at all concerned, then most areas do provide either carpet shampooing or steam cleaning of furniture is another alternative. But I would concentrate on your hard surfaces and making sure your equipment that is used by lots of different people with lots of hands touching it throughout the day.
And from the times you've brought your son to the cochlear implant clinic, what do you feel are the most risky things that we do in the clinic in terms of infection transmission? Is it looking in ears? Is it checking a child's middle ear? Or is it the fact we're in the room with them for 2 hours? Is it the waiting room? Is it the toys? Is it all those things?
I think the toys are always, whether that be a paediatric ward or an outpatient or not just an audiology clinic, toys are always an issue. And I know that audiology departments try and provide hard toys rather than soft toys so that they are cleanable. And that's always a better thing than soft toys that are intricate with difficult ridges or grooves, etc., which are difficult to clean. Often children like to put things in their mouths as well, young babies, if they're having audiology appointments, just making sure that, you know, it's something that is easily cleanable. I think the risky times are, for example, yes, obviously, looking in ears, making sure that your instruments are clean. Obviously, taking impressions, ear mold impressions, for example, making sure that your hands are clean while you're mixing the ear mold that goes into the syringe to make the impressions. All these things make a difference. And then again, I suppose, you know, it sort of quite nicely leads on to PPE. At the moment, you know, we are asking healthcare professionals to wear a surgical fluid-resistant face mask, plus or minus eye protection when they're seeing patients in clinics. So I suppose that leads nicely onto PPE.
Yes, and is that something you could give us an overview of? So obviously the face coverings, is that going to be just if we're within 2 meters of a patient, would you say? Or is that 1 meter now? Or should we always wear the face covering if we can?
So wherever you can, always wear the face covering. Patients or your clients need to lip read. So you need to work with your infection control teams in your areas and look at alternative means of staying safe, but while actually providing an appropriate service to the hearing impaired. So for example, wearing a mask if you're really up close, i.e. Looking inside ears, etc., might be appropriate, and then taking it off when you step back. Using clear visors to cover your face so that you can socially distance but still have a visor on, so that your clients and your patients can see your lips moving, but you're still protected. Obviously adults, where they possibly can, should your patients and your clients should wear a mask as well. But you know, that needs to be risk assessed depending on the needs of the patient or the client. So my advice would be to your members is to work alongside your infection control teams, get them on board, tell them what your issues are, and work alongside them. And most infection control nurses are very pragmatic in their risk assessments and understand your needs if you describe them to them. And I certainly have had long discussions with the Yorkshire Cochlear Implant team about the use of visors as an alternative to masks, but also socially distancing, so that anybody who needs lip reading can receive that support.
Thank you, that's so helpful. And would you feel confident, Claire, to bring your son to the Cochlear Implant Clinic at this time?
Oh yes, absolutely. I think that most of your hearing impaired will understand the appropriate actions that you're taking in your clinics and will appreciate them. Certainly if they're preparing for their cochlear implant surgery and they're anxious, I think the actions that you're putting in place, whether it be alcohol gel at the entrances, making sure that your staff are washing or gelling your hands frequently, cleaning surfaces, offering masks to those that can use them, and also saying, well, I'm going to step back from you while I talk to you, and I'm going to wear a visor while I take my mask off. And so that everybody understands and appreciates that. And I think that my son would be more than happy with that.
Brilliant, thank you so much. So Lisa, moving on to you, you're the coordinator of the North East Cochlear Implant Programme, and I believe that you in your centre have been seeing patients perhaps throughout the pandemic, am I right? Tell us a bit more.
Thanks, Helen. Yeah, so when lockdown first happened back on the 23rd of March, we did cancel all activity for a period of 2 days to give us a chance to look at PP requirements and kind of plan what we were going to perhaps offer as a service in a trust. During that time period, we took the Royal College of Surgeons guidance along with the letter from yourself, Helen, on behalf of BCIG to our senior management team. That basically supported seeing pre-verbal children who couldn't wait longer than 3 months because that might result in lifelong delays in speech and language acquisition. And our senior management team were very supportive of that, and they said that they would consider our patients as category 3 time sensitive for pre-verbal cases. So yes, we did remain open, but only for pre-verbal time sensitive cases, meningitic or sudden losses during that time period. A few considerations and challenges that we had over that time period were week 2 of lockdown, we had a lot of staff redeployed, so we were quite thin on the ground ourselves. So a lot of the staff that remained behind worked very hard, often additional clinics. All our cases that had to be considered for surgery, they all had to go to the theatre prioritising group called the T100 group, and they met several times a week, and we had to go and present our cases on an individual basis. And when we presented those cases on an individual basis, we were presenting those with all of the specialities across the trust. Can you still hear me there, Helen?
Yes, all good, thank you. Sorry, somebody knocked on the door. Can you believe it?
That's okay. So yeah, so we were presenting each case individually, and during the lockdown period, we were lucky enough, fortunate enough to do 11 pre-verbal paediatric cases. For those cases, we had to do extended COVID consents for them all. The consent appointment went over to being virtual consent with signing on the day of surgery. All those cases had pre-COVID swabs. We followed strict trust guidance with PPE. I looked like something out of CSI in Introp. They had an X-ray 48 hours before, and all our post-op reviews were carried out virtually as well, with an additional sight and ear check at the switch-on appointment, with patients just advising to keep the ear dry until the audiologist did examine it. Switch on. For our switch on, some adaptations that we made were, it was trust guidance at the time that children were only allowed to be accompanied by one adult, but we did seek the permission of our CEO for exceptional case on this, and she was happy to support actually parents from the same household at that time attending, so 2 parents attending for paediatric switch on or tune-in. And the rationale behind this was actually we would actively encourage the second parent to engage, to distract the child during testing. And that meant that actually we weren't breaching that 2-metre social distancing unless it was absolutely essential to. It also had the added bonus that actually children of this age will respond much better to a familiar face without a mask in front of them for testing. So we were finding get more out of the sessions if you did it that way as well. During that time period, our rehab team saw all of their paediatric caseloads virtually, and that went very well. We were doing virtual device preferences, and we made a few adaptations to that, but finding our feet with that really. We also had a lot of upgrades booked in for the end of March, and unfortunately those got cancelled face-to-face appointments. So what we did is we actually pre-programmed them in clinic and sent them to patients and basically virtually troubleshooted those. So that made a lot of patients happy that they ended up getting the upgrade device as well during lockdown. What we did know and notice and was a bit of a concern during the period is the rapid decline in our referrals that we had. And obviously that was a bit of a concern. So we looked a little bit more closely at our NHSP activity, and we monitored that for the 3 previous years from March to May of the same time period. And actually we found a reduction in 50% compliance of the KPI2 indicator, which is basically when a child fails the initial screen, they should be followed up within 28 days. So we saw a significant drop there in 2020 compared to 2018 and 2019. And overall, that resulted in actually, for that same time period, we had 5 children diagnosed in 2018 and 2019. We only had 1 child diagnosed with severe to profound loss over the March to May period this year. So we are a little concerned about that, because obviously, as we all know, this is going to result in late referrals to us, which is going to make our job even harder to implant these children in that critical time-sensitive window. So that's kind of our experience during the lockdown period. And now we opened all other outpatient services on the 11th of June for implants. So now our challenge really is reducing the footfall in the department, because obviously we've got reduced capacity because we're adhering to social distancing in the waiting room, both from a staff and patient perspective for safety issues.
Gosh, thank you, Lisa. I mean, you guys jumped right on it, really, didn't you, in your trust? I think I've struggled a bit that each trust is so different. It seems a pity, really, that we don't have a little bit more maybe central guidance that we could have all followed, really. It seems each trust is reinventing the wheel in perhaps its own its own way. And so going forward now, how are you going to prioritise your patients? What on earth are you going to do going forward?
Yeah, I mean, we have one of our biggest challenges here, we've found as a team, is when we are sticking to social distancing, obviously that is severely reducing our capacity. So one of our biggest challenges we've got here is our dynamic, uncontrolled social distancing scenario of the waiting room. Unless you're very fortunate, we share our waiting room with our ENT colleagues, the rest of our audiology services and speech and language therapy. And actually we've got one seat in auditory implants throughout the working day. So we've got a significantly reduced capacity. So what we have done is we've looked at ways of both increasing the waiting room capacity for ourselves, but also reducing the amount of patients that are requiring a face-to-face appointment to make sure we can see those urgent priority cases coming through. So to reduce the face-to-face contact, we've looked across the medical, rehab and audiology arm of the service. Some of the medical arm I've already covered, so it's virtual appointments for consent, post-op reviews. Audiology, we are actively promoting patients enrolling in choice and U2R, and that can aid as a really good kind of annual review, but also aid to triage, so you're only bringing in patients who essentially need that face-to-face contact. Like I said, we've done upgrade kits direct to the recipient, but we're looking at exploring that with the companies as well, which will also free our capacity up a little bit because we're not programming them. We've got one-stop assessments that we've been looking at setting up as a team for our adults. So we've looked heavily at the patient flow there for those. So basically making sure that actually from the audiology appointment through to the rehab, through to the medical arm of that, actually we've got volunteers or runners helping with that. So the patient's not having to go back to that one seat we've got in the waiting room to maximise our capacity really. Because, you know, we've got the staff, but we just don't have that waiting area. Within the waiting area itself, we've looked at additional areas near to the department that can be held as like a holding bay with like a buzzer system, so we can call patients straight through into clinic. We've looked at text messaging and phone calls direct to patients. A lot of ours travel by car into appointments, so actually if we could have them wait in the car and then text or an automatic phone call to them as soon as it's time to come directly into the clinical room rather than taking that additional capacity in the waiting area. And obviously maximising our off-site clinics as well to help with that. So, I mean, when we've looked at kind of the changes we've made to reduce the face-to-face contact in clinic, we've projected that from our medical arm, it will reduce face-to-face appointments down to 31%, for our rehab arm down to 33%, and for our audiology arm down to 58%. So we are hopeful that we can reduce footfall enough in the department in order to kind of maximise our capacity there to see the real urgent cases that need to see us face to face.
Gosh, you must be just exhausted, Lisa. This is absolutely incredible. You must be exhausted. So I'm going to ask you a bit later on what changes you would like to see happening when we're out of the COVID pandemic. But for now, I just wanted to move on to Sue. So Sue, the BAA, the British Academy of Audiology, has been amazingly proactive in helping audiologists with COVID guidance, which I'm sure you must be updating every few days really as the situation changes. Obviously your guidance is just for audiology, but many of the things are the same in the cochlear implant clinic in terms of the way we're dealing with patients. Can you give us a summary, please, of those excellent documents? We have them links on our website, on the BCIG website.
So we started off with a very clear stop everything, and it was a definite because of the cough reflex. So a lot of what we do in terms of looking in somebody's ear and in terms of otoscopy, but also impression taking for any kind of device was a problem because initially we felt we weren't convinced that the cough reflex wasn't an aerosol generating procedure on its own. So we had to spend quite a lot of time when we first researched the adjusted guidance to get that information. There was nowhere that was dealing with such a small area of, you know, so they were talking about COVID positive patients, and very little was out there in terms of COVID screened patients, so people that we were screening as asymptomatic. And I know there was a guidance that was around, at the moment we have to treat everybody like they have COVID, but it did make it really difficult to get true guidance about just a very simple cough that we might get if we were looking in somebody's ear and we were close. So I guess the first thing we had to do was try and evidence that, and finding the Infection Prevention Society had done some work on that, asking for some very specific guidance about what are, in Claire's terms, I'm sure, quite non-intrusive things compared to what else is going on around the hospitals. You know, we are close to a patient, but we can limit how long we're close to them. As audiology is cochlear implant, we don't have to get in there for a long period of time in each appointment. So for us, trying to get any sort of guidance that was very specific has been quite a challenge. So we have managed to acquire some guidance that says twice now that cough reflex is definitely nothing we should worry about. It is as difficult as breathing and speaking also generate aerosols, but they're not something we should worry about. We've tried really hard to, and I hope Claire's noticed it in our guidance, to really emphasise how clean you need to be, that this isn't about the PPE, this is about hand hygiene, this is about hygiene in your clinic, and this is about making sure that you do all the preparation before they come in, that Lisa's done in spades, working out, you know, any other way to see somebody. If there isn't, then how do we bring them in safely and quite, you know, with minimal contact with other people in the waiting areas. All of that stuff is in the guidance, because we're trying to cover both hospital practice and community practice and private practice in the document. So we had to be really specific for some of those that don't have infection prevention teams. We found the tricky bits, and it was really nice to hear Claire saying that a lot of people are being pragmatic. Tricky bits have been guidance on soft furnishings, because of course most clinical areas don't have carpeted rooms and walls that have got soft furnishings on them. So trying to find very specific guidance on that has led us to nursing home guidance, because they of course have soft furnishings, but again, most of that is for people who've been exposed to COVID, who we think are suspected COVID patients. So trying to get good advice around that, and trying to be pragmatic that you're not realistically going to get your room steam cleaned every night has been interesting. And we've got such variation still. So it was interesting, I think it was you, Lisa, wasn't it, that was saying the variation has been a problem. And there's huge variation across the country. We're still getting infection prevention nurses coming in and saying, no, we're going to coat this whole room in plastic. And that to me is even more risky. So I'm kind of looking at Claire and she's nodding at me, because my understanding of everything that we've read, everything that we've been trying to put together, once it falls onto the soft furnishing, an aerosol is less likely to come up, because we're not, I wanted to put in the guidance, don't let your patients lick the carpet or the walls. But apparently that isn't going in a national guideline, but you know, just between us folks, that's really the risk. And actually, like Claire said to us, we're not touching the walls, we're not routinely touching the floor. I would say for toy drops, I'd want that taken out of the circulation with the child until it's been cleaned properly. But you know, in reality, we're not touching the walls, we're not touching the floors. And air conditioning, Claire, I'm getting a lot of questions about air conditioning at the moment from different trusts. And again, pragmatically, what I can find is all about COVID cohort areas where people have got COVID. or are suspected of having COVID, and actually where we've screened and we've screened really carefully, then the chances of us having a problem with our air conditioning are mitigated quite a lot. So I am trying to persuade people that if they have got a fresh air setting, to put it on that, but if they haven't, then it shouldn't be it should be a risk that is understood, but a very small risk, to have your air conditioning on. Otherwise, we're going to have a lot of hot and sweaty audiologists in soundproof rooms over the summer, which nobody really wants. So the guidance gets updated as quickly as we can. So there will be another update out this week. The update, I was saying earlier to the other presenters, will be around changing 2 meters to the required social distance, the required physical distancing of your area. We want to try now to prioritise the document almost like a traffic light system, so that if there is a local lockdown that happens, audiology doesn't get switched off entirely again. It goes to the remote and the curbside and the postal services, and we think that's important to get in place between now and probably July. What else is in that document?
That does seem a good idea, as you say. If things do come down to like local changes, if we can just kind of move up a level on the audiology guidance rather than, as you say, starting all over again, that would be really.
Yeah, and we went very simply for if you're within 2 meters of somebody and if you're not, in terms of PPE requirements, because we didn't want to start listing individual procedures. The only individual procedures that are on there are a couple of weird ones like the wax removal, because there's a difference. So after the otology guidance came out, there was a clear understanding that the middle ear mucosa might be virus bearing, and they couldn't say it wasn't. So we had to add something in about wet ears, wet perforations. But I think one of the things we're trying to make clearer this week is what is an aerosol generating procedure, because I've got people talking about if we drill a mould, which isn't in a patient ear. Claire wants to speak. Go, Claire.
Right, aerosol generating procedures. What are they? Okay, so an aerosol generating procedure is really a procedure where you use powered air. And so, for example, if I give you a very simple example, like a dentist's drill or dentist suction, is very much the fact that it creates a very fine particle mist, which is aerosolized and travels a lot further than normal droplets. So the difference between an aerosol and droplet is normal droplets are from coughs and sneezes. So that's the cough that comes out through your breath when you cough or you sneeze, and they are quite large droplets from a particle's point of view, and therefore those are the ones that will travel between 1 meter and 1.5 meters, which is where the social distancing came from for 2 meters. So there's conflicting evidence about whether they travel 1 meter or 2 meters, but that's where the large droplet comes in, which is where coughing and sneezing comes in, which is why we use a fluid repellent mask rather than an FFP3 tight fitting facial respirator. Give you another example of aerosol generating. Eye surgery, they use a very fine water jet to drill a hole into an eye for eye surgery.
Yeah.
And that, yeah, exactly. The things I've learned recently. And so that creates obviously a very, very fine aerosol mist, and obviously eye surgeons are very close up to the eye when they do that. So that's another example of an aerosol generating procedure. So if you were to ask me about whether doing impressions or ear molds is an aerosol generating procedure because it can make the patient cough, I would say no.
Okay.
And I think that's where we've got to. So I think we are really comfortable with the only things we've said may possibly cause an aerosol generation are air calorics on a wet ear, where we've got a direct connection to the middle ear mucosa that is a fluid covered membrane, and we're using a jet of air. I'm kind of going to fall onto tympanometry on a wet ear, which I thought was contraindicated, but I was told that that's how they decide what wax removal procedure to do with this child that they can't get true otoscopy on. So I'm going to say no to that, because again, I think that's the movement of air.
Yeah, so it's powered air, isn't it?
Yeah, so those are the ones. But everything else we've said is in audiology just isn't. If you have a wet ear, you could still take an impression because you're not pushing air over it. So I think that was the big one for us, is getting that really clear definition into the guidance this time, because I think the definition is, as Claire says, really clear. I just think people have got a little bit hooked up with it at the very beginning.
Thank you, Sue. Thank you, Claire.
Okay.
So thinking about the journey for adults and children with cochlear implants, I know, Lisa, you've said you've cut down your rehab appointments by a third, which is really impressive. And I know at Guy's and St Thomas's, Sandra, you have set up a really impressive remote rehabilitation program. Can you tell us about how you're doing it, please? What system are you using? What are the pluses? What are the minuses? Has everyone been able to access it? Tell us more.
Yeah, so across both teams, peds and adults, all the rehab teams, so the teachers of the deaf and the speech and language therapists, are all working remotely. And I think we'd been trying to get a bit of remote rehab and assessment off the ground prior to COVID, but obviously this is, you know, we've all had to launch into it at 110%. Now, of course, it's interesting, you know, that every trust is probably different in what technology staff have been able to use in terms of platforms and such, but our trust has been very supportive in terms of getting everyone set up remotely at home to be able to offer remote appointments. So headsets, laptops. So there was a bit of a delay in getting all of that equipment to staff, but all the staff now have got a laptop with a webcam. A good quality headset we felt was essential as well. So there's a sort of technology side, and then also in terms of what platforms we've been using. Our trust sort of slightly threw the rule book out in terms of information governance and what platforms we could use, and said we could use any remote platform that the patient can engage with for the foreseeable future during this COVID period, which has been revolutionary in terms of allowing us to just have a go with an awful lot of types of formats. So even FaceTime, WhatsApp, Zoom, whatever. Attend Anywhere has been the mainstay of our hospital, but what we've been working very hard towards is finding the right platform, especially for the adult patients, that's got good quality captions, essential. Absolutely essential. And we did a bit of a review and found that Google Meet was particularly good in the way it captioned, because it shows who's actually talking clearly. Whereas when we use Microsoft Teams, the caption runs along the bottom, and the color, you get a little color of blue around the person who's speaking for their initials, but if people talk over each other, it sort of just gives you a continuous stream, and then it's quite difficult to know who said what. So we've approached our information governance and IT service, and I think the key thing is it's about finding someone in your IT department who will learn to understand about our caseload and the unique needs of our caseload around captioning, what we need, because in the longer term, this is going to carry on, and we need a platform that's accessible from the patient end and easy to open and connect to with any type of technology. And you also need to know what kind of organization you are. So we're a Microsoft organization, not a Google one. So my idea of using Google Meet might be okay now, but it's not what our trust is going to invest in. So we're doing a piece of work with Microsoft at the moment, where we've given them a number of case studies, particularly around our adult patients, and they're using that to help think about Microsoft Teams and how that could be used for our unique patient population going forward. I think what you will
find, amazing, isn't it? That's amazing that they're investing in that.
Yeah, they are. So I think it's really important to engage someone from your IT. Obviously we've managed to sort of get a shoe in with meeting Microsoft, and we've got a meeting on Friday, and hopefully some of those features or extra features. So for example, we were talking about the importance, if you have an interpreter on the call, that you can make sure that the BSL interpreter would be big on the screen and you have control over that, about their captioning as well. And what you may well find is that you might be using some of these systems now within your hospital, but they haven't switched on all the features and given you access to all the features. So I'm aware that Microsoft Teams does have a patient-facing booking sort of pathway, which a lot of hospitals probably haven't switched on because they're using it just for team meetings amongst staff rather than externally. So again, it's pushing your IT department to find out what features have they actually activated. Also around, alongside that, the extra features that allow not just captions but interpretation into other languages as well, which again, the software, the facilities are there. It's just about getting through IG and IT to get that set up so you can use it with patients. So I think, you know, there's a lot going on that we can use now, but there's a lot of facilities on these platforms that I don't think most of our trusts would have locked down. So we need to get them to open them up so we can use them with our patients. And also, I think there's an onus on the big companies, Google and Microsoft, if they want trusts, because they're free, you know, they're given sort of slightly free license to a lot of centres in the NHS at the moment to use their facilities. There will come a time when they then, you know, start wanting to be paid for those, for the sort of that the hospitals will end up having to have a contract, and we need to make sure whichever route we go, Google, Microsoft or otherwise, that they meet our specific patient need. But saying that, we've had some really successful appointments with our adult patients. And I think our patients have surprised themselves. I think there's a lot of anxiety, especially for the adult patients, around even attempting a video conference. I mean, it fills us with dread, you know, the thought for them of even making that first connection. So we've done quite a lot of work on the letter and the information we send to the patient to reassure them that there is captions that we can type if they can't follow us, trying to build that confidence beforehand, and let them know, sort of, we've got some user guides for the patients as well.
That's really interesting you say that, actually, because I guess thinking of it, a lot of adults with cochlear implants might have had wildly unsuccessful Zoom calls with their families over the past 2 or 3 months, where everyone's talked at once and there's been children and dogs and doorbells and things. So it's really interesting that you say the information you're giving and the reassurance.
Yeah, it's all about the preparation. It's all about making sure they've got that set up. And I think a couple of our patients who have been particularly anxious or resistant, or just think they wouldn't be able to, you know, we've had a member of staff sort of doing a trial contact, you know, just to get them onto the system, because again, you know, this is not going away. This is going to be the future and a blended service. And also, you know, the advantages is you know, traveling into central London in rush hour and paying hundreds of pounds. It's not just about infection, but actually in terms of people's lives. I mean, all the work you've done, Helen, around that is, you know, it's something that can be a really real positive. I think what's also nice from a paediatric perspective is a lot of our team, we're running our case history appointments under assessment, remotely, and we have the key audio, the key SALT, the key TOD from the team on the meeting. We've also have the family, but we've also been able to invite the local TOD and or SALT to also join with the parents' permission, and we've been doing that for the post-op switch-ons. So, you know, rather than trying to sort of negotiate a visit on a certain day and maybe not having too many people, there's, you know, they're able to sort of participate in a lot more of the appointments because everyone's a bit more available to all link up, you know, at the same time. So
yeah,
that's been a real positive.
Kind of a level playing field thing, isn't it, really? That in a way, it does mean that people can be more accessible. I've certainly had a few appointments as well where I've had the local teacher of the deaf in on the appointment, and again, you know, it wasn't hard to do because they could spare half an hour in their day, but they couldn't spare a whole day to come to Southampton probably.
Yeah, yeah.
Gosh,
So
well done. You guys have done really well.
I think the information that you've gathered about Microsoft Teams and Google would be invaluable to all of us because of those with learning disabilities or those with English as a second language. I'd like to know more of what you've achieved, please.
Yeah, absolutely. I'd be more than happy to, yeah, sort of share, what we found out, and also what's coming. You know, what's in the pipeline with Microsoft and Google and such like, and also, you know, again, understanding, you know, we've all had to upskill in terms of understanding if you invite someone as a guest that they might not have access to captions, you need to give them presenter rights, or just share your screen is quite a quick tip. We've done quite a lot of work on building our resources of assessments and rehab material that we can screen share and run some language assessments remotely. So the KELF, and there were some other pediatric assessments that can be done virtually, you know, not with everyone, but with a fair number of children. And we've had some fun making up some sort of functional listening games and activities for the post-op phase with some of our children and teenagers, where we've been doing quizzes with them and sort of letting them see us to start off with, and then switching our video off and giving them multiple choice quiz questions and just seeing if they could participate. Again, we're asking the parent the other end to tell us if our voice is coming through clear, and downloading a free app in terms of a sound level meter. Again, I know it's not completely scientific, but it gives us an idea at what volume our speech is coming through at, and giving us an idea if that sort of young child, teenager, is able to follow speech with and without the lip patterns, closed set, open set. We've had some fun quiz games, getting the parents involved, getting the local TOD to answer some questions, and then being able to feed that back to the audiologist to help us decide if it's essential to bring them in for another mapping or not, or whether we can leave them a bit longer. So I think there's an awful lot of stuff around rehab, but also functional listening, sort of teasing that out, that can be done through this medium, and can give really useful information back to the audiologists, especially when we're trying to minimize in-clinic appointments and really prioritize who really needs to come in and who doesn't.
Really impressive. Thank you, Sandra. That's great. And yeah, it will be great to kind of follow the work that you're doing with Microsoft and find out a little bit more. And of course, another big reason why people might come to the come to the Cochlear Implant Centre is for audiology, so for tuning or mapping. And is that the kind of the final frontier, really? Amanda, tell us what you've been doing in Belfast in terms of managing your caseload for mapping.
Hi everybody, hi Ellen, and thank you BCIG for inviting me to share our remote programming experiences on behalf of the Belfast team. I have some slides to share with you, if that's okay. So I'll just try to. Okay. Okay, so hopefully everybody can see these. So just a brief history of why we basically made the decision to start trying to attempt remote programming was the fact that we're community based. And from the 30th of March until further notice, our centre became a primary and community COVID assessment centre, with all services being temporarily stood down, which meant our team had to basically pack up and move to an emergency hub in a private hospital. So the clinical staff set up remote working from home to cover emergency repairs and troubleshooting, while the medics looked after wind and site problems, including an explant, and the admin staff were relocated to a nearby hospital. So the new working arrangements posed a bit of a problem for us, in that at the time of lockdown, we had a total of 14 peds and 6 adults in various stages from switch on to week 5 post. We had initially been thinking of doing some form of remote programming or some form of remote care package. Since the change in NICE guidelines, I'm sure like all other CI centres, we had to start thinking about new ways to absorb more patients, but still run at the same high standard of care, while overcoming challenges such as staff shortages and room and space restrictions. Luckily for us, our colleagues in Southampton conducted the first switch on in the UK, and they kindly shared their protocol with the UK centres. And from this, we were able to tailor and create our own protocol in collaboration with services within the Belfast Trust, such as IT, information governance, and externally with the help of from Cochlear UK. This is an adapted diagram of our test setup. My colleague Nicola and I set it up initially with a tablet, and after running some practice sessions between our 2 houses, basically, we were ready to go. The remote kit contained the Microsoft tablet, which had custom sound and TeamViewer installed in it. Custom sound was password protected so that the patient couldn't access it. We decided to use a wired programming pod instead of the wireless USB connection, because we thought that would be an added limitation if patients had poor internet access in their home. We also laminated instructions and included them in the kit, so the patient had a step-by-step guide on how to set the system up. The patients agreed to come into the hub and pick up the kit and leave it back with us. So the clinician was basically at home and the patient is at home. We used Microsoft Teams as our audio and video system. This was the one that our trust deemed to be most suitable for the purpose. Stuff like FaceTime and Zoom, just we weren't allowed to use them. So Microsoft Teams was what we used. So after consent was gained by the patient, information was emailed to the patient on what actually Microsoft Teams is, how it works, and how to install the app. Both the clinician and the patient used their own devices to access Teams, mainly on a phone or a tablet, and our admin team made the team booking. This booking was CC'd to the clinician, the parent or the patient, and also our SLTs joined in the session. In one session, we also had interpreters, an Arabic interpreter who helped us. We have a family of 3 Syrian brothers who all got implanted in February. So basically any professional can attend the session. We used TeamViewer as the remote control to control the software, and TeamViewer, the patient simply relays their unique remote control ID and a password, and the clinician can gain control of the tablet and access custom sound in the normal way. To date, from the 30th of April until present, 11 peds and 4 adults have partaken in remote programming. All of them were cochlear nucleus 7 patients with CI 612s or CI 622s. One of the patients was a hybrid, and during this time, Cochlear also kindly facilitated us in the provision of a loaner laptop so that we had 2 kits on the go. The initial findings, it went better than expected. Patients actually embraced the technology and they were grateful for the input and support from us. As I said, 11 of the 14 peds and 4 out of 6 adults participated. It reduced the risk to all of the parties involved. There was minimum PPE required, as only brief face-to-face was required for the kit pickup, and there was no decontamination of toys or any of the clinic equipment. It may be virtual, but the patients were still very engaged, especially the peds who were more comfortable in their home environment. And we also had flexibility with the timings of our appointment, which ensured we got the peds at their most active and I suppose most involved in the session. The disadvantages that we have found so far was not able to do otoscopy, data login and sound field audiometry, although we can still do the ling sounds and do some functional listening. It's a Microsoft-based software, so it's limited to specifically Microsoft tablets and laptops. And with this, it's also dependent on the speed of internet connection. Currently at the moment, our patients still need to come in and pick up the kits. Moving forward, as a result of the increased demand for this type of support, Cochlear UK acted quickly and were able to push for a change in their CE markings to enable them to support the clinics by supplying loaner equipment to do remote programming. I suppose in the future, if we could have a couriered service which would deliver the kits directly to the patient, this would have big cost saving analysis in terms of patients' travel and the time out of work as well. We would like to run an internal audit, specifically patient satisfaction survey, to see what the patients actually thought. And it's really given the team the confidence to use remote programming as a mainstream tool if and when it's needed in our clinic. Thank you.
Amazing, Amanda. Thank you. I think you're right that perhaps we've all been surprised really in the past few months what our patients can do. And I think perhaps it's a lesson to us not to kind of worry too much, you know, give people a chance really. And I think if you can empower people, give them the confidence that they are engaging with remote tools, then it's all good. And let's see now if we have any other questions from the audience. We're running out of time a little bit, unfortunately. It's also fascinating. If anybody thinks of some questions afterwards, then please, you could email info@bcig.org.uk, and I'm sure I could pass those on. I think the questions we've had so far have been answered, thank you, by the panelists. So what are people thinking? Do you want to carry on working like this? So let's say in a year's time, things have moved on and the risk level is really low from COVID or any other kind of virus. Would you like to have your service go back exactly how it was before the COVID pandemic, or do you feel that the innovations you've introduced could actually benefit people long term? Amanda, is that a yes or no?
It's a yes to not going back to how things were run. I think this whole unfortunate COVID era has given us an opportunity to create some innovative areas and moving forward. And I think it means that we can offer a more patient-led care system, especially children in their own home, more relaxed environment. So definitely. Yeah, virtual clinics, I think, is a definite way forward. Yeah.
And perhaps we're doing really is making a more kind of a needs-based service, aren't we? So by helping people as much as we can at home and perhaps triaging them in that way, then we can decide really who are the priorities really for coming to the clinic. Sandra, are you happy to carry on like this in your team?
Yeah, absolutely. I completely agree with everything Amanda said. It's a great opportunity. So out of something horrendous has come a real opportunity. And I've just been, I think everyone on this meeting and everyone listening and all my colleagues, I've just been so impressed with the innovation and the desire to keep putting the patients first and trying to find ways to see them through this, but actually using technology that's there, and I think pushing to make sure that technology is set up how we need it to be to make this a more long-term sort of a way of working. Absolutely.
Lisa, the same for you? You feel you're happy to carry on like this to some extent?
Yeah, definitely. I agree with what Amanda said as well there. And certainly in this initial period, the feedback that we've been getting from families has been very positive as well about the new ways of working. You know, a lot of our families have other children that got implanted not in the COVID period, so have a direct comparison. And actually that feedback's been really positive. And like I say, with regards to time to travel, making it more patient focused and centred, and just little things that we've noticed, like doing the virtual device preferences, actually the wider family is engaged and actually joined that chat. So we might have had sons or daughters of our older population join in, and it actually becomes a lot more family focused with the permission for the patient, obviously. So yeah, it's really, really positive.
Oh yeah, no, it is fascinating. Okay, we have reached 5 o'clock on Tuesday afternoon. So I'd just like to close this by saying again, thank you so much to the panelists for giving up your time and sharing your experiences with us. Like you said, Sandra, I'm absolutely amazed at kind of the innovations and the changes that have been implemented in the cochlear implant field across the UK is just in 3 months is absolutely astounding. So well done, everybody. It's just amazing to see. And this recording will be available on the BCIG website, hopefully from tomorrow, and hopefully with captions in the recording. So again, thank you so much for your time, panelists and attendees. Thank you for your questions, and thank you as well for finding the time to spend this hour with us. Thank you, everybody. Goodbye.